The next session would be a panel discussion on management approach to growth disorders. I request the moderator, Dr. Meena Kumari Mohan, to occupy the podium. The panelist, Professor Dr. Sridevi Naaraayan, Professor Dr. Durai Arasan, and Professor Dr. Ashwini Godbole to occupy the dais. I request the moderator to introduce the panelist and conduct the proceedings of the panel.
Good morning, everyone. Thank you very much for the organizers for giving us this opportunity. So this topic is on management approach to growth disorders. So we have excellent panelists. First one is Dr. Ashwini Godbole, who is a director from Chiranjeev Child Diet and Development Center from Pune. And we have both professors of pediatrics from ICH Chennai, Dr. Durai Arasan and Dr. Sridevi Naaraayan. And myself, I'm a pediatric endocrinologist from PSG Super Specialty Hospitals in Coimbatore. So the topic is short stature approach. So looking at this slide, we're not sure who is tall and who is short. So the shorter person might look at the other person and think that he's tall, or the other person might look at the shorter person and think he's very short. So we need to have norms of what is short stature and how do we define short stature. So for that, may I ask Dr. Ashwini to explain how do you define short stature, please?
First, I would like to thank the organizers for giving me this opportunity. So while defining short stature is a common clinical concern shared by many parents in the routine pediatric OPD as well as in CDCs. And one has to remember it is a symptom and not a diagnosis. There are various physiological, pathological causes which will come over, but first the definition. The short stature is below, when a child's height is below the third centile for mean height for that age, gender and population, or if the height is following more less than 2, or the child is not growing at all, or crossing 2 or major percentile lines between the 2 years and puberty. Thank you.
So this is the graph that explains the standard deviations. So the middle one is the 0 and -1 and -2 standard deviation. So anything below the -2 standard deviation, which is exactly less than the third centile, would be classified as short stature, which needs evaluation. So what does actually growth mean, Dr. Durai Arasan?
Good morning, and thanks the organizer for the opportunity. Growth literally means it's a quantitative change. It is basically measured based on the increase in height and the weight. As the previous speaker rightly put, it is the single most important parameter to assess the well-being of the child, both physical and mental. So it is a very, very important tool to assess this growth. So the growth is taken care by many factors. In the intrauterine period, it is mainly the maternal nutrition and the intrauterine environment. During the infancy and up to 2 years, the infant nutrition, and it slowly switches over to the genetics, and then the growth hormone comes into play. At the later stage, during the pubertal growth spurt, the growth hormone with the sex hormones plays a role. So multiple factors act. They are not mutually independent, but they have overlaps within it. The environmental and the socioeconomical status has its own influence, and it adds up to the growth of the child. So assessing the growth, which is the single most important parameter, is more important.
So now, what do you mean by ICP model of growth, Dr. Sridevi?
At the outset, I would like to thank the organizers for giving the opportunity. This ICP model or Karlberg model is basically a mathematical model for measuring the linear growth of humans. So it is divided the whole period from the later half of the intrauterine life to maturity is divided into 3 periods of infancy, childhood and puberty. That is what ICP stands for. So this is divided so because in the 3 phases, the growth is determined basically by different mechanisms. For instance, in the infancy, the growth is mainly determined by the nutrition, in the childhood by growth hormone, and in the puberty, it is due to interplay of sex steroids and the growth hormone. So this model, it tells you, it is an instrument to tell you what goes wrong and to exactly pinpoint and have an approach towards the growth disorders.
So one has to remember that during puberty, it is the combination of nutrition with the good thyroxine and growth hormone levels and sex steroids. So it is one on top of the other and not one at the exclusion of the other. So why are males taller? We all know that boys are always taller than girls. So can you tell us how it can happen, Dr. Ashwini?
Yes, sure. So boys have got 2 additional years of prepubertal growth. A greater amplitude is seen in adolescent growth spurt in boys. A large prepubertal height is seen in case of boys, and an average female height is 13 centimeter less than the average male height. So all these things, they are explaining why the males are taller than the female.
So now we have to define what is normal growth velocity. So may I ask Dr. Durai Arasan to talk about it, please?
Yeah, the growth velocity is not the same as we saw by what Sridevi said, the ICP model, the infant, childhood and the pubertal model. So the most of the height is gained during the infancy, that is 25 centimeters per year, which is not there in any other time of the life. So that is going to be the most important. And in the next 2 years, it slowly shifts to the genetic potential in addition to the nutrition. So in the second year, 10 centimeters, and in the third to fourth year, it is 7 centimeters. So put together, we can remember 4 years, 100 centimeters is the cutoff. So 50, 75, and for the next 2 years, another 15. So 100 at 4 years, which will be the easy. And after 4 years, from 5 years till puberty, the rule of 5. So after 5 years, 5 centimeters per year till the pubertal growth spurt. So anything less than 4 centimeters after 5 years, if you regularly monitor the growth, which is going to be the alarm bell, and we need to work on that.
Thank you. So what is the growth velocity curve and how do you go about it, Dr. Sridevi?
Yeah, growth is a dynamic process. So if you look at the height of a person at one particular time, it is just a snapshot picture. We don't know the trend, how they are growing, whether they are growing well or not. For that, we need to have growth velocity curves. What do you do in growth velocity? You plot the growth once and then again after a fixed interval, minimum of 6 months. For instance, if a child comes to you at 3 years and the child's height is 93 centimeter, and then the child comes back again after 6 months and it is 96, then 3 centimeter has gained over 6 months. That is, the child is growing at the rate of 6 centimeter per year. And we plot this in a growth velocity, height velocity curve. So again, we have norms. We have the centiles for the height velocity. We have it separate for boys as well as girls, and it is going to vary depending on the age of the child. And here, one thing what I want to emphasize is anything less than 25th centile is taken as abnormal and not the 3rd centile.
Thank you. So now we need to find out how often should we monitor growth in a clinical setting. What is the minimal requirement for that?
So coming to the minimum requirement, first, as the esteemed speaker like Dr. Vaman Khadilkar sir and previous speakers have mentioned, the growth charts to be used, and for first 5 years there should be WHO growth charts, and between 5 to 18 years it should be IAP charts. So for the children below 2 years, the measurements which are important are the length, the weight of the child, and the head circumference. The frequency, how much time it should be the growth monitoring done at the time of birth, then the 6 weeks, 10 weeks and 14 weeks. Then at the 6 months, 9, 15 and 18 months, that is paralleling the vaccination. And afterwards, every vaccination visit, it should be the opportunity to monitor the growth. Between 2 to 5 years, the height, weight and the head circumference should be monitored every 6 monthly. And after the 5 years, it should be the height and weight, BMI, along with that, the SMR staging using Tanner's stage. And that time the monitoring should be done every 6 monthly till 9 years, and after 9 years it should be done annually. So this is a simple way to follow the growth monitoring.
Thank you, Dr. Ashwini. So now, how would you go about evaluating short stature, which is the topic for today? Dr. Durai Arasan.
So having known what are all the factors and how to monitor the growth, whenever a child presents to us with a short stature, the evaluation has to be comprehensive. So right from the history and the physical examination, whether it was an SGA baby or it is a syndromic baby. So we heard so much about SGA, syndromics and other things. And coming to the growth assessment, we need to ascertain the first important thing is an accurate measurement of the height and the weight. So that is most important, and plotting it on the appropriate charts. So we heard Kadilkar sir talking about the growth chart. So the appropriate chart has to be used. And the most important thing, as Sridevi said, was growth velocity. The growth velocity is the dynamic measure of the growth. If you plot it at a single cross section, it is a snapshot. So more than the snapshot, the growth velocity has to be monitored, and the mid-parental height to ascertain whether the child is growing as per the genetic potential of the child. So that is the next important thing we need to assess, and of course the most important, bone age. If the bone age is delayed, we have more time for the child to grow and we can take corrective measures. So the bone age gives an important clue what is happening with the epiphyseal fusion. So it has to be a comprehensive approach whenever you do an evaluation of a short stature.
Thank you. Now, what are the clinical cues can you expect, and what significance do they have when one examines a child for short stature? Dr. Sridevi?
On general examination itself, you may be able to pick up many signs which may be pointers towards the etiology of the short stature. For example, if you are going to find a dysmorphic child, you think of syndromic issues. If you are going to find midline defects, it may be due to hypothyroidism. Pallor can point towards chronic anemia as the etiology, or CKD. Vitamin deficiency signs, you can think of underlying malnutrition or malabsorption as the cause of short stature. Hypertension will again point towards CKD. Jaundice, clubbing, you think of underlying liver disease, and certain features like frontal bossing, depressed nasal bridge, crowded teeth, small penis, these are all peculiar to growth hormone deficiencies. And hyperthyroidism, you can have features like goiter, impalpable thyroid, or coarse skin, delayed tendon reflexes. And Cushing syndrome, they obviously present with proximal muscle weakness, striae, obesity, and round face and short fourth metacarpal developmental delay can point towards pseudo-hypoparathyroidism. And features like visual field defects, optic atrophy, optic nerve hypoplasia, papilledema point towards hypothalamic causes like hypothalamic tumor, septo-optic dysplasia. And other features, like there are certain other features also. For example, if you have midline defects, it is more in favor of hypopituitarism. Similarly, blindness, single central incisor, they are also in favor of hypopituitarism. Rickets, pallor, you think of renal causes. And metacarpal shortening, not only pseudo-hypoparathyroidism, Turner's syndrome too, and murmurs can point towards congenital heart disease as the cause of short stature. And deafness, you have to rule out Turner's syndrome, other intrauterine infections. Tetany, pseudo-hypoparathyroidism, and mental retardation can signify underlying hypothyroidism and genetic syndrome. So a proper general examination is mandatory before we proceed to specialized investigations.
Thank you for the exhaustive list. Now, how do we measure growth? I think we've been talking enough about it, but let's formally find out how to do that from Dr. Ashwini.
Yeah, so while measuring the growth, the two instruments that should be in a general pediatric OPD as well as in a CDC, one is infantometer and second is the stadiometer. While going ahead, the weight of the child, the length of the child up to 2 years, and then the height should be measured. Head circumference should be measured, especially the weight height should be plotted by using the appropriate growth charts. The parental height should be also measured. Some time should be spent for measuring the height of the father and mother. Then plotting the height weight as well as the mid-parental height should be calculated. And as respected Dr. Khadilkar sir has showed with the new charts, the mid-parental height calculation doesn't require much time. So with that, the mid-parental height should be plotted on the growth charts.
Thank you.
And while going ahead with the two explanations here, just quick. The infantometer should be used in the for the child up to 2 years. The baby should be lying supine, and then the baby's head should be in the aligned with the body of the baby, and the head should be gently held. Regarding the knees, they should be gently placed, and the baseboard can be maneuvered according to the requirement. Regarding the next slide, sir. The stadiometer, the norms that should be followed, that first the child should be standing without the footwear, then the occiput of the child along with the both shoulders, back, then the buttocks, and the next is the heels. They should be touching the wall. The lower border of the eye socket, it should be in the same plane as horizontal as external auditory meatus. The child should look straight ahead, and the right angle block then slides over and touches the child's head. The accuracy should be up to the 0.1 centimeter.
And one should remember that though a child of 1 year can stand, you should still measure the lying down height, because standing height can be about 0.7 centimeters shorter, rather than measuring when you are making the baby lie down and get the length of the baby. So now, how do we calculate and plot mid-parental height and target height range if we were not given the specified charts that Dr. Kadilkar showed before? Dr. Durai Arasan?
Okay. So as Dr. Sridevi mentioned, the history and the physical examination carries in much importance. So once we are done with the syndromes and the chronic illnesses or the SGA baby, then we need to mainly assess the genetic potential of the baby, whether it is growing as per. So for calculating the mid-parental height, it is the average of the father's height, mother's height, and 13. The 13 is the correction factor. It is the normal difference between the average male and the average female, and it is divided by 2. So this will give us what is meant as the mid-parental height. And the target height is 6.5 centimeters above and below this mid-parental height. I will explain you with 2 case scenario. Thanks to Hemchand for courtesy the slide and the scenario. Suppose if an 8 years old girl child whose height is 117 centimeters, if you plot it on the chart, it is at around the 10th percentile. So if you see, she is low normal or in the 10th percentile. So now we have to see whether the genetic potential is correct. So if you take the mother's height 150 centimeters and the father's height 163 centimeters, correction factor of minus 13. So the target height is 150. So giving the target range plus or minus 6.5 centimeters, 143.5 to 156.5. So if you plot it in the chart, you can see that the target height is also in the 10th percentile. So the child is growing as per its genetic potential. So possibly maybe an familial short stature. We don't have to do much about this child. The next slide. So this is an other scenario where you can pick up an pathological child. It is not growing as per its growth potential. Suppose a 10-year-old boy coming at 132 centimeters, if you plot it and see, he might be on the 25th percentile. Suppose if you calculate the mid-parental height based on the mother and the father's height 168, 184 and the correction factor for boys plus 13, the target height is 182.5 centimeters and the target range is 176 to 185, and if you plot it, it is at the 90th percentile. So the child is growing at 25th percentile, but the mid-parental target range is in the 90th percentile. So still we can pick up that the child's growth potential, genetic potential is not fully achieved. So there are lots of significance in doing an proper mid-parental height calculation and plotting it and checking. And as Sarah explained, the IAP has made it very simple with the combined chart, pediatrician friendly combined chart, where you can look up for the mid-parental height and the target height.
So one must remember that the same vigilant measures has to be taken when you are measuring parental height as well as you do the child's height, because that's where is the basis of measuring the mid-parental height. So you should be very vigilant in measuring the parent's height with the same accuracy as well. Now, how do you go on to do a pubertal examination after measuring the height and weight, Dr. Sridevi?
Yeah, pubertal examination is very important in pre-teens and teens. So we do what is called the SMR staging or Tanner staging. In boys, we take into account the genitals, that is the size of the scrotum and the pubic hair distribution. In girls, we take into account the breast size and the pubic hair distribution. So Tanner stage 1 means it is pre-pubertal and Tanner stage 5 means it is adult type. So in between, and particularly regarding the growth spurt of boys generally corresponds to between Tanner stage 3 and 4, whereas in girls it corresponds between Tanner stage 2 and 3. So whether the Tanner stage is congruous with the growth spurt, that also we not only the staging, we need to look at that also.
Thank you. So usually I remember it as a letter T, where in girls it's always the breast development followed by the rest of the development, and in boys it's from the downside, so it's enlargement of the testicles and then the other signs of puberty appear. So now, what is the significance of bone age? There was a comprehensive workshop done by Dr. Hemchand very well yesterday. We won't be able to touch upon to that extent, but we'll just discuss a few points about it. Dr. Ashwini?
Yes. So one should remember human hand bones they develop with the puberty and not with the age. So it should be kept in the mind. While thinking about the bone age, it has to be done from the non-dominant hand. So usually the left wrist should be considered for that. Here one should use the Grulich-Pyle method, which is used worldwide, but it needs training. And the another one is the Tanner-Whitehouse method, which has got a criteria which is established for the set stages in skeletal maturation. So specifically for the bone age, if there is a delay by 2 or more years, it is to be taken as a significant one. And for older children, if there is a delay by 12 to 18 months, it can be a normal variation with or without the chronic systemic illness. So while interpreting the bone age, this should be kept in mind. And here is one picture depicting about the pathological short stature and constitutional short stature. So we can go ahead.
Yeah. So now, how do you calculate the height age and weight age for children, and what is the significance in doing so? Dr. Durai Arasan?
So to assess whether the child is growing appropriately. So first what you do is you need to accurately plot the height and the weight of the child. So in the example given, so so you first plot a same age child with two different markings. So one at around 140 centimeters. So if you just plot it and then draw a line across to match the 50th centile of the chart. Then draw a vertical line down and the corresponding age is going to be the height age of the child. So similarly, if the child is going to be short at around 80 centimeters or so, then the height age is going to be very less. So this is the way to check what is the height age of the child after plotting the height accurately. Similarly for the weight age, if you plot it and then draw a line to match the 50th centile of the chart and then draw a vertically down line to intersect the x-axis and then to find out what is going to be the weight age. The next. So we'll just check how we are going to practically use it. Suppose if the weight is going to be more affected than the height, possibly we can interpret it as a malnutrition or a chronic systemic illness. Suppose if the height is going to be more affected, if you calculate the height age, it is going to be more affected than the weight age, then possibility of an endocrinal disorder or a syndromic short stature has to be thought about. So this is in nutshell about the importance of the chronological age, height age and the weight age. In a normal child, the chronological age, height age and the weight age has to be within 1 year of difference. So it has to be almost equal. When it is because of a malnutrition or a systemic disease, as we saw, the weight age is going to be more affected than the height age and the chronological age is going to be more. In cases of an endocrinal abnormality, the height age is more affected than the weight age. In cases of an nutritional obesity, it is the reverse. The chronological age is going to be small. The height age is going to be more than the weight age. So that is going to be a nutritional obesity. So with this parameters, we can pinpoint the etiology of what is happening with the child.
So now, how do we simply classify short stature for ease of proceeding what to do next?
Yeah, short stature can be due to a variety of causes ranging from genetic, endocrine, systemic disease or environmental. Genetic causes like constitutional delay in growth and puberty and familial have to be ruled out before we term the short stature as pathological. And the other genetic causes of short stature are syndromes and the skeletal dysplasias, which invariably cause disproportionate short stature. And endocrine causes are a common lot which cause short stature and a treatable lot. The most common one being hyperthyroidism and then the growth hormone deficiency and Cushing's. So as a part of your workup, we do all these hormone levels. And more than the specific etiologies, underlying systemic illness are a very common cause of short stature in children, particularly your chronic cardiac disease, your chronic kidney disease, other chronic diseases like cystic fibrosis, celiac disease also have to be thought of, and inflammatory bowel disease is though rare. All these things have to be thought of before you proceed with specific investigations. And environmental causes are last but not the least. It can be due to malnutrition per se or due to child abuse or neglect, or psychosocial short stature is also a known entity.
Now we move on to what are the physiological causes of short stature that we see on a day-to-day basis. Dr. Ashwini?
Yeah. So while considering the physiological causes of the short stature, first one is the familial short stature. So in a routine pediatric OPD or CDC, if one of the parent is accompanying and the height is the main concern, then the other parent's height should be asked. The family history should be sought for. So this is one of the cause. Second cause is constitutional delay in growth and puberty. And third important point which we have commonly heard about is the catch-up growth. But in large for gestational age babies, it is the catch-down growth which should be kept in mind.
Now, moving on to comparing and contrasting constitutional delay in growth and puberty and familial short stature, how do we differentiate the two? Dr. Durai Arasan?
Okay. So the two most common physiological variants where we don't have to do much about it but have to identify them perfectly. So the regular monitoring of the growth helps because the time of onset of the growth faltering, if you check in the constitutional delay, the growth faltering happens at around after 7 years. Whereas in the familial short stature, there is no growth faltering, but the child grows at a low normal growth velocity. It will be the growth will be continuous, there won't be any faltering, but it will be at a low normal. If you take the bone age or the skeletal age, it will be delayed in constitutional delay, it will be normal in the familial short stature, matching your chronological age. The puberty will be delayed in your constitutional delay, whereas in the familial short stature, it may even be slightly early. So next slide please. Next slide. Okay. So to have it as a pictorial depiction, if you see the normal growth is going to be smooth across, whereas in the constitutional delay child, if you can carefully look at around 7 to 8 years, there is an growth faltering for crossing of the percentiles. So this also signifies the importance of continued growth monitoring. So, but later with the pubertal growth cycle, the child catches it, whatever it has lost, and the final height is going to be the normal adult height. So you don't have to do anything big. This is comparing the familial short stature and the constitutional short stature. In the familial short stature, there is a low normal growth. If you see the growth velocity, there is going to be a continuous growth, and if you plot it, it is going to be there in the lower percentile, but there is a continuous growth. But it will be matching the target height, which is the target height is of the parents or the genetic potential. So though the child may be short adult, it will match what it is of their parents. Whereas in the constitutional short stature, there will be a delay at around 7 to 10 years before the pubertal spurt. Later on, they catch up during the puberty, and then they reach a normal adult height. So these two things are the most common cause of your short stature and the common variants which needs to be diagnosed.
So now, we've done all this. So how are we going to start investigating? What are the first line of investigations that one would do? Dr. Sridevi?
Yeah, after the history taking examination and the anthropometry, we proceed to basic investigations which are done in all patients with short stature after ruling out the physiological variants. We do a hemogram, a complete blood count and ESR to pick up anemia, which could be the cause. And we do blood glucose levels to rule out diabetes and glycogen storage disorders. We do a RFT and LFT to pick up any chronic kidney disease or chronic liver disease. We also do calcium, phosphorus, alkaline phosphatase levels to pick up any metabolic bone disease. So apart from this, we do a chest X-ray to pick up any tuberculosis or any chronic infections, and then we do the bone age in the non-dominant hand, and we also do the thyroid function test. These are mandatory level 1 investigations for all children presenting with short stature.
So now if all these investigations come back as normal, we need to have another battery of investigations to do as next line. So what are they, Dr. Ashwini?
So while going for the specific cause for the short stature, the venous blood investigation level 2, venous blood gas will be analyzed below 3 years of age for the metabolic workup. Fecal calprotectin will be done for the children more than 10 years with the inflammatory bowel disease. Tissue transglutaminase antibodies specifically for the celiac disease, and IgA deficiency to IgA levels for the immunodeficiency to find out. Karyotyping in a girl with, depending upon the requirement, pelvic ultrasound. While considering the skeletal surveys, the left wrist and the hand, then along with that the skull AP and lateral and pelvis AP, these X-rays should be done. And for specific syndromic features, when there is a family history, the genetic testing, the panel testing of the genetic workup should be done.
Thank you. So how would you evaluate growth hormone axis, Dr. Durai Arasan?
The growth hormone axis is nothing but the growth hormone IGF and IGF-PB3 axis. So it is one of the main axis which determines the linear growth of the child. The growth hormone mainly acts on the liver to produce the IGF-1. Though IGF-1 is also produced by other tissues, it is mainly by the liver, and the IGF-PB also by the liver, which acts on the target tissue. Next slide. Next slide. So we will just see in case scenario how we evaluated a child for an growth hormone deficiency. So a 9 years old male child was brought to our OPD. The mother has noticed the child to not have an progressive increase in the height for around 2 years. It was initially taken to a private practitioner. The private practitioner has evaluated the child after plotting it on the chart for an IGF level 1 and found that to be low. So then they referred the child to us. So the growth hormone axis, the IGF-1 determines whether the growth hormone is acting. If the IGF-1 levels and the IGF-PB3 levels are normal, we can say that the growth hormone function is going to be normal. We don't have to move on to the growth hormone or other dynamic stimulation tests. If it is going to be low, then we need to proceed ahead with the growth hormone dynamic test. Okay, so this is the child. So if you can see the child, it is a 9 years old child. I don't know whether you will be able to see. The height of the child is around 97 to 98 centimeters. So the chronological age of the child is 9 years. The height age which we said at 4 years is going to be 100. It is less than that, 97 or 98 centimeters. So the height age is 4 years, and we did a bone age for the child. So we did a bone age assessment. The bone age came out to be 6 years. In institute we get the radiologist opinion, and they give us the bone age based on the ossification center. So the child had 6 carpal bones along with the appearance of the head of the radius. So the bone age was around 6 years. So now if you see the height is more affected, the bone age is affected but lesser. So we proceeded ahead with an investigation. So initially before going in for a growth hormone dynamic test, it is mandatory you rule out a thyroid deficiency, because in a state of an hypothyroid, your growth hormone dynamic test may not be truly representative. So we did a thyroid profile, and the thyroid profile was within normal limits. Hence we decided to go ahead with the growth hormone stimulation study. In the institute we normally do a clonidine stimulation test. So we did a clonidine stimulation test, and the peak at around 90 minutes was around 3 nanograms per ml. So any levels less than 7 is going to be diagnostic of a growth hormone deficiency. Remember, diagnosing your growth hormone deficiency is not adequate. So you need to do an MRI in all children wherever you go for a growth hormone stimulation test, because it may turn out to be a pituitary hormone hypothalamal issue. So we did an MRI for this child, which turned out to be an hypothalamo-hypophyseal pituitary hypoplasia. So it becomes mandatory that we need to check for other hormonal deficiency. So we did an baseline 8 AM serum cortisol. It was around 5.9 micrograms. So as of now, the child doesn't have any other deficiency apart from the growth hormone deficiency, but the child has to be monitored because the other deficiencies may manifest in the future. So to put it in a nutshell, the peak stimulated growth hormone concentration less than 7 is going to be consistent with growth hormone deficiency. As we said, thyroid has to be ruled out before doing a dynamic test. Similarly, an sex steroid priming is recommended at pre-pubertal ages, around 10 years in girls and around 11 years. So if you are planning for a growth hormone stimulation test at around the pre-pubertal age, sex steroid priming has to be done. The serum concentration of IGF-1 and IGF-PB3, because they don't have a little circadian variation, they are a good predictor. Before going in for the dynamic test, you can do those things. In children less than 8 years, the IGF levels are relatively low. So you can depend on the IGF-PB3. If it is more than 8 years, we can go for IGF-1 levels. Next slide. Remember, don't do an random growth hormone levels, because it is an pulsatile secretion and it is not going to be of any use.
So next is a case presentation by Dr. Ashwini.
So this was a 1-year-old child who was brought to our pediatric OPD with poor eating, poor weight and height gain. Mother had anemia when the history was taken. During pregnancy she had anemia and the baby was IUGR with birth weight 2 kg. No other significant history. Baby was breastfed for 1 month but later on it was bottle fed with cow's milk. Parents had visited pediatrician twice or thrice only in the first year. On examination the baby had pallor. The weight of the baby was 6.5 kg and 68 centimeters was the length. Her lab investigations were done as a primary level of investigation and iron deficiency anemia was diagnosed. With the treatment, the baby's weight came to normal. Then again, after some months, baby came with the complaints which were of the reactive airway disease and there were frequent bouts of cough and breathlessness. The baby was managed, but then the necessary investigations were done and the treatment was given accordingly. But after that again, baby's length was, when seen, it was less for age. So we can go ahead. This was the first growth chart plotting at 1 year with the length at 68 centimeter between first to third percentile and weight was 6.5 kg below 1 percentile. Head circumference was 43 centimeter. Now we can go to the lab investigations done, which quickly I will tell hemoglobin was 7.3 and the iron studies they told about serum ferritin and iron low with TIBC increase, microcytic hypochromic anemia and teardrop and few cells of pencil cells. And with the second chart plotting we found out that there was the length was 87 centimeter and weight was 12 kg. So these changes were found when we gave the necessary iron supplementation as it was told by previous speakers and the nutrition guidance was given. Specifically we told to stop the bottle feeding because as I usually tell the parents that just like Putana Maushi is to the Krishna, same way bottle is Putana Maushi for all the babies. So I told them to stop bottle feeding. Then I told them specifically the focus should be with the diet containing iron, then the specifically the calcium and the protein. So considering that there was the improvement found, maternal anemia, they got the consultation with the gynecologist and total the growth charts were very useful.
Thank you. So next is a case discussion by Dr. Sridevi.
This is a very short case. We had a 5-year-old girl who came with a dull look and expressionless face. She was lethargic. She had some hyperpigmentation, ascites. Her breast development was minimal. She had edema around the neck. And when we took her height, it was plotted on the growth chart. She was found to have short stature. It was below the 3rd centile. And we did the basic investigations. Her bone age was less. It was retarded. It was only 3 years. And her mid-parental height was in 25th centile. So her centile was not corresponding with the mid-parental centile. So as a first-line investigation, we proceeded to do the thyroid profile. The free T4 level was decreased and TSH level was way increased. So we diagnosed her as hypothyroidism. We put her on thyroid supplements and on follow-up her growth improved and so this is a growth chart showing her serial evaluation, serial follow-up visits, and on follow-up she was clinically she improved as well as she was able to have some gain in stature and she she outgrew the short stature and her height corresponded to her genetic potential.
Thank you. So the common causes of short stature in India are mostly familial and CDGP, which is 80 to 85% of the time. And after that comes chronic systemic disease and malnutrition. And then is endocrine disease, mainly hypothyroidism, and after that growth hormone disease and Cushing's if they are taking steroids in various forms. And not to remember low birth weight syndromes and rickets and skeletal dysplasia if they are abnormally short. So the take-home message is clinical assessment always as any other pediatric case. Do not forget pubertal staging, serial measurement and plotting over a time to measure the height velocity. And we've talked about CDGP and genetic. And just reassurance might help with continuous monitoring. And invest in a good stadiometer. Measuring height along with weight and documenting during every clinic visit is very, very important. Plotting on the growth chart helps you identify the problems early and to monitor and to treat them at the appropriate time. careful looking at the genitalia. At least during the first visit, you can pick up micropenis, hidden testicles, or undescended testes, etc. And again, as Dr. Durai Arasan mentioned, not to do random growth hormone levels as an initial investigation of short stature, because it is not going to add anything to the management, and to do pubertal staging as well, and to work as a team for the better care for all our children. Thank you very much for your valuable time. So hopefully you're all having all these gadgets with you and start monitoring short stature in a better way. Thank you for the opportunity once again. Thank you.